We are going live on Zoom, YouTube.
Janvi, please, can you mute yourself? Dr. Janvi, can you mute yourself? Dr. Swati, Dr. Janvi.
Okay, so we are live on YouTube now. And we'll begin in 2 minutes.
You'll post the link?
Yes, I'll do that in a bit. I am sending it to you on WhatsApp.
Okay.
Are you in your office, Dr. Tamkin?
No.
At home?
My study, yeah.
Oh, you got a big, lots of books.
Yeah, very old editions, Some of my professors, gifted me those books, so I don't want to part with them. Many of them are new, yeah. But old, Iron Donalds, old Williams, older versions. Yeah, Holland Blues, all those.
Yeah, I don't even know where my books went.
Jeff Coates, yeah.
Now it's all online.
Yeah, everything is online. We hardly get time to.
But I really like Iron Donald.
Dr. Vishal Kataria, can you please mute yourself? Dr. Vishal Kataria, yeah, thank you.
Well, we can start if Veronica joins.
Yeah. So, good evening, everyone. I'm Dr. Asna Ashraf, Joint Secretary, Stillbirth Society of India. I extend a very warm welcome to our esteemed colleagues, distinguished speakers, and participants to today's webinar, organized by the Stillbirth Society of India. I request everyone to please mute themselves.
Continuously 3 months.
Please mute yourself. Yeah, sorry for that. So it is an honor to have such a dedicated group of professionals who have gathered here to discuss an issue of profound importance, understanding the causes and prevention of stillbirths. As we know, stillbirth remains a deeply challenging and emotional subject, not only for the families that are affected, but also for us as healthcare providers. Today's webinar is a crucial opportunity to delve into some of the key aspects that help us in our ongoing efforts to reduce the incidence of stillbirths in India. I am privileged to welcome our
May I just interview? I think please mute everybody. Mute everybody. You are the host?
Yeah,
unless your LDL goes very high, like LDL cholesterol is. Dr. Bushra, can you mute yourself? Bushra, can you mute yourself?
So I'm privileged to welcome our esteemed speakers for today's session, who are both exemplary leaders in their fields. Professor Deepika Dekka, a renowned expert, will be presenting on torch infections and stillbirths, a topic that is vital in understanding the infectious causes of stillbirth and their prevention. We will have 30 minutes for her presentation, followed by a 10 minutes discussion period. And following that, we have Dr. Veronica Arora, who will be shedding light on the genetic causes of stillbirths. She too will have 30 minutes for her presentation, with 10 minutes allocated for discussion. I encourage all the participants to engage actively in the discussions following each presentation, as your questions and insights are invaluable and contribute to our shared learning. Once again, I thank you all for being here today and for your commitment to advancing our understanding of stillbirth. Let us now proceed with today's agenda, and I would like to introduce our first speaker, Professor Deepika Dekka. I'll be sharing her slide. I request everyone to please stay muted. Professor Deepika Dekar is a senior consultant fetal medicine,
हाँ वो तो खाली हो गया है
medicine center Dwarka, which is a center for ICOG Foxy certificate course in fetal medicine. She is the founder and secretary general of OFMAG and MFM academic groups. She's an ex-professor and head of the unit Maternal Fetal Medicine AIMS Delhi. And she's also the past chairperson, Fetal Medicine and Genetics Committee, Foxy 2006. She is the past founder, vice president, and past president, Society of Fetal Medicine 2011. She was also the ex-vice chancellor, Srimant Sankardev, University of Health Sciences, Assam, and is a member of the National Medical Commission Advisory Board, a representative of Assam. This was in 2019. She was also the ex-director of AIMS Kalyani, West Bengal, 2018, and the past chairperson of ISOPAB North Zone, 2002. She has trained in fetal medicine on a WHO fellowship at the Georgetown University, Washington, D.C., USA, and an ICMR senior scientific fellowship on fetal endoscopy at King's College Hospital, London. And she has authored several books and book chapters, and she has more than 250 publications in international and national journals and various research projects. And she has guided more than 100 research scholars and has given plenary talks and orations in international and national conferences. I'm going to stop sharing now, and I invite Professor Dekar to give her presentation. You can start sharing now, ma'am.
Thank you very much, Dr. Kane, Professor Kane, Dr. Veronica. So is my slide visible?
Yes.
Yes.
Right. Thank you very much for the invitation. And I'm very happy that you have created a society for stillbirths, which is going to focus mainly about prevention of stillbirths. And, basically our country is one which is very rapidly trying to decrease the stillbirth rate. And so this society is therefore going to be very, very useful. And I hope every member of Foxy also joins so that we can focus and discuss stillbirths. So my topic is on torch infections. And torch basically stands for Toxoplasma, O for others, rubella, cytomegalovirus, and herpes. But in the other infections, we can include each and many infections. So why they are called torch? Because they usually have some of the factors which are very common, like hepatosplenomegaly, petechiae, and jaundice. These are common in these infections, but if you investigate them further and you see that they could be quite specific, the importance of this group of infections is they can be quite asymptomatic in the mother, but can cause real havoc in the child, in the fetus, and stillbirths is one of them. The clinical triad, as I said, the classical triad for them being grouped together, jaundice, petechiae, and hepatosplenomegaly. So, but then if you do the laboratory tests, and there are certain clinical features which can distinguish one from the other. The pathogenesis, the problem is it's quite unpredictable, and it depends upon many factors. Most importantly, the gestational age. And then as placental and fetal immunity evolves during pregnancy, then also it can have an effect. The type of maternal infection, whether it is a primary or an acute infection, or it is a reactivation or reinfection, those things also might be used. Again, there are some lines coming on my slide. I don't know from where. Red. Can the IT person remove them, please? Yeah. So in the timing of exposure, what's most important is in the period of organogenesis. That is the first trimester. If there is maternal infection, maternal viremia, maternal protozoemia, then there can be miscarriage. The fetus can get infected and there can be a sporadic miscarriage. I'll be talking about what it happens in RPL, but not now. And the other thing is it can have teratogenesis, because this is the time the fetal organs are forming. Heart disease can occur, cataracts can occur, so much more. And the growth potential of the baby can be hampered, leading to IUGR, which is the most important cause of stillbirths. There can be also affection of various organs, leading to non-immune hydrops. In the second half of pregnancy, the infection which goes from the mother to the transplacentally to the fetus is much more, but the effect of the infection is much lesser. So there can still, however, be IUGR, neurodevelopmental delay, or no sequelae. It has been known since this paper that I found of 1979. This is a so old paper where people have attributed the torch infections to stillbirths. The association with growth restriction is that the prognosis relies on the etiology, what actually happens. So basically, the maternal infection is localized to the placenta, where there are vascular changes. There may even be genetic or chromosomal changes, which leads to the affection in the fetus, and there can be IUGR or it can be the stillbirths. So mainly it is thought to be cytomegalovirus, and it can be there in about 5 to 15% of IUGR cases. But other infections like varicella and of course rubella, toxoplasma, HSV has not been implicated very much, but there are now lots of studies which come in, which have, after doing the diagnosis in first trimester abortions, we find that herpes simplex can also come up the vaginal route and infect the baby. So it is not that herpes infects only at the time of delivery. It can also cause in utero problems. The investigations which need to be done, which can diagnose, are basically serology. Serology for the syphilis as well as the torch infections. So we generally do IgG and IgM. And avidity is a test I will discuss later, which actually tells you how you can time the infection to the period of gestation. And this can be very useful, especially to diagnose early onset and severe IUGR. Then when you're doing the anatomical survey, especially the second trimester, then the presence of echogenic bowel, calcifications, mild ventriculomegaly, these calcifications can be just around the ventricles, which is called periventricular, or they can be inside the brain matter or inside the liver. There can also be hepatosplenomegaly, and we can see that very clearly on ultrasound. There can be placentamegaly. It also affects the amniotic fluid, and oligoamnios is more common than polyhydramnios. Again, the effects of these torch infections can be seen on the fetal structures like microcephaly, and so there can be cortical vein malformations, and if many organs are involved, there can be non-immune hydrops. So it's very important in these ultrasound finding cases that we do the torch test. Usually in the second trimester, it is not wise to do the maternal torch because, you cannot time it, because infection in the second trimester is not very dangerous. Infection in the first trimester, however, can lead to consequences. And because it is more than 4 months since the first trimester, we cannot do it if we do only IgG, IgM, or even avidity. Therefore, most of the times when we have ultrasound features like echogenic bowel, ventriculomegaly, and you want to rule out torch infections, you need to do amniocentesis and torch PCR. There is no other way. Again, there are so many of these studies. The RCOG Green Top guidelines have said that fetal infections can be up from 5 to even 10% of the SGA fetuses. And generally, it is considered to be about 5%, maximum up to 10%. FIGO also recommends that in cases of IUGR, you may, especially the early onset IUGR and those fetuses which have some ultrasound features, you must do karyotype, and you must also do the polymerase chain reaction for infections agents, especially when they are lesser than the 3rd percentile and early onset. Data have changed over the years, and even in 25, the global stillbirth rate was told to be about 18.4 per 1,000 live births. Obviously, it is very different in different parts of the world. The WHO aims to reduce stillbirth rate to 12 per 1,000 by 2030. And this is reaching the every newborn national 2020 milestones. So there is a plan by WHO to reduce the risk factors, especially infections in pregnancy, which may cause stillbirths. And this was published in the Lancet. Other organizations like UNICEF also is giving a lot of attention to stillbirths. And they say that, of course, we also know that there is an unequal burden of stillbirths within countries and within different countries. And it is the most important indicator of access to quality of care during pregnancy. Every day in 2021, data from the UNICEF report showed that there were more than 5,000 babies stillborn at 28 weeks or more. So the load is really, really very big. How does torch infections cause IUD? So there can be other infections also besides this, like malaria, chlamydia, mycoplasma, listeria, and even tuberculosis. And these, you see, in CMV, in the developed countries, the common infections causing stillbirths is actually cytomegalovirus. They cause direct cytolysis, and in the placenta as well as in the fetus, loss of cell function in the various organ systems. We know that in sub-Saharan Africa, it's malaria, which is very, very important, and the other parasitic infections. So ultimately, it's either the fetus which is infected or there is placental vascular insufficiency. So then on ultrasound, if you find that there are cerebral calcifications during autopsy, then they have been associated with infections. So when you're doing an autopsy for stillbirths, as we are expected to do, all stillbirths should have an autopsy unless you know that this is because of PIH or because of something else. So if you find intracerebral calcifications, that actually tells you that the fetus may either be having toxoplasma or cytomegalovirus infections. Idiopathic non-human hydrops fetalis, you must look for parvovirus. You should send the tissues for parvovirus infections. And also maternal serology for parvovirus and torch infections agents should be done in unexplained NIGF. Other infections, especially which can occur at lesser than 23 weeks, are E. coli, Streptococcus, Enterococcus. So the placental pathology, you must send a little tissue of placenta for histopathology in all stillbirths. And you might find chorioamnionitis, phenicitis, villitis, necrosis, and you can also do the viral stains and look for these infections. So as a routine autopsy of stillbirths, we must include placental biopsy and torch PCR. So as I said, the various organs, all the organs of the body are involved, but the kidneys are most often infected, followed by lungs and the liver. The CMV inclusion bodies can be seen in epithelial and endothelial cells, and as well as in the bile ducts. The inflammatory reaction around the CMV inclusions are also to be seen. So the diagnosis can be by doing a fluorescent in situ hybridization, which we do mainly for the chromosomal test, and PCR for the infections. Going to the specific infections, toxoplasma, we know that it has a cycle through the cat, and the cat passes on these infections through the feces, the oocytes, which are ingested by the pregnant woman while eating either raw or less cooked fish, meat, or handling of litter, and then unwashed vegetables or unwashed fruits. So these can go through the maternal intestine, and then from there it causes a tropozoid, it causes a bacteremia, after which the placenta gets infected for about 3 to 4 weeks, and only after that the fetus also gets infected. Universal screening for toxoplasma has been a routine in places where there is endemics. France is a place where the government actually says that you should have all women tested for toxoplasma before pregnancy, and if she's not immune, she must have the torch test, the toxoplasma test, and every month of pregnancy. The same thing goes for Brazil. And with these screening procedures in these countries, they have found that they could control plasmosis, because these are countries where a lot of steaks, pork, and meat are eaten. Whereas in other countries, like in UK, they have not found a very high prevalence of toxoplasma. And so it is not included in their national program. In India, of course, we don't have much data. And these various studies, just published now in WHO Eastern Mediterranean region in 2023, says that the seroprevalence of IgG toxoplasma ranges this much. So it means that the person has been infected naturally at some time during their lifetime, but the IgM is lesser. So this toxoplasma gondii, they probably have come in contact with cats, drank unprocessed milk or undercooked food, unwashed raw vegetables, and the outcomes could be abortions, stillbirths, and preterm labor, IUGR. So women who are not immune to toxoplasma need to be monitored. There is also a condition called chronic toxoplasmosis, and this is more common in women who are immunocompromised. So in them, this toxoplasma cysts, they could lie in the uterine musculature, and every pregnancy could be infected, but to a lesser degree than with the acute infection. Cytomegalovirus virus infection is a very common. It is one of the commonest infections. It is the commonest infection, torch infection in developed countries, and the commonest cause of sensory neural deafness. It can cause birth defects, sensory neural hearing loss. It is, of course, endemic worldwide, and usually younger children are infected. And there is usually seroconversion annually, especially around the time of early winter. So young women who care for preschool children or are sexually active within 2 years before delivery, they are at higher risk of CMV, because it is also said to be a sexually transmitted disease. In CMV infections, again, it has been found that the virus replicates in the lymphatic system and the small muscles in the blood vessels in the villi, and congenital CMV infections impairs placental development and function, and therefore leads to stillbirths. The most important, as I said, that these infections, they are more prone to affect the kidneys. And you can also, it is also standard for diagnosing CMV infection through urine, from the bladder of children, from the urine of children. So it's the kidney damages which are more common in cases of CMV compared to the other infections. Rubella is also called German measles or the 3-day measles. And the first time it was detected by Gregory, who is an ophthalmologist, is that it could cause cataracts. So though it is a disease of the childhood, I had done a study in college students, and we found that 80% were immune, but 20% were non-immune. So non-immune women would be at risk of getting the infection during pregnancy. Of course, the rubella immunization has drastically changed the risk for this, but we still see, as we had done this study a long time back, that 20% of women are still susceptible to rubella and therefore would need a rubella vaccination. So the effects of rubella are basically growth restrictions, stillbirths, can cause microcephaly, cataracts, cardiac defects, and so on. So the infection is more dangerous in the first trimester of pregnancy. After 16 weeks, the infection is not really, does not cause congenital malformations or IUGR. Herpes is another condition which is very dangerous, but it is now seen, which can cause stillbirths, especially can cause neonatal deaths more importantly. If it is disseminated and the baby has had a vaginal delivery through a canal which is infected, vaginal canal, or which is infected with herpes virus active. The other lesser grades are there, grade 1, grade 2, which can cause infections in the mucous membranes or even cause CNS abnormalities. But disseminated without more treatment, the mortality is 100%. Syphilis and malaria. Syphilis is also counted in the storch, other infections, and they can cause stillbirths because of the high maternal fever. There can be respiratory distress, placental infection, which leads to that. In syphilis, 25% of all stillbirths have been, in sub-Saharan areas are because of syphilis. Fortunately, in our country, we are routinely doing the VDRL tests, but now it has been seen that there is a resurgence of syphilis in the developed countries. So this is what is like a chancre. There is this congenital syphilis can occur, the primary, secondary, and the tertiary syphilis. Tertiary, fortunately, we don't see, but pregnancy complications are a high rate of stillbirths. Almost all pregnancies with syphilis are affected, and the fetus gets affected in about 60 to 80%. So it's very, very important cause of stillbirths if not treated. Parvovirus is another infection because we're doing the tests now. We see that they can cause, the mother may have no problems at all, but the problem which this causes that there can be bone marrow crisis, there can be hydrops fetalis because it affects the bone marrow, and there is severe anemia. So if you can diagnose the anemia and treat the baby, you can save the baby. So this slide tells you who are the women who are at high risk of the TORCH group of infections. Toxoplasma, I already told you, women who eat lesser cooked meat, who do not wash vegetables very well, or are exposed to recently weaned out kitten. Rubella exposure, especially in the rubella non-immune, those who have not been vaccinated and do not have the IgG. So if they are exposed to anybody in the room, an exposure is termed as 15 minutes face-to-face contact because this is a droplet infection. So they can get the rubella infection. CMV, again, high-risk sexual behavior, STD, again, occupational exposure, especially for CMV and as well as for parvovirus. Women who are teachers, especially looking after young children, daycare personnel, nurses, cafeteria workers, they are the ones who are at risk. So prenatally, we can see that it depends on the organism. Like most of the organisms affect in the first trimester and throughout pregnancy. Herpes virus is the one that can cause infection during delivery. Now, there is a condition called acute viremia when there is an acute disease, but there can be also reinfection, especially for rubella. So if a person especially has taken a vaccine and the immunity is because of the vaccine, over 12 years or so, the immunity wanes, it becomes lesser, and the person could be at risk of a rubella reinfection. So that is the reinfection. And then there is another condition which is called, this is because of the immunity, and then the vaccine, especially for CMV, we can have reinfection. The period of gestation also, as I had said earlier, is very important. For toxoplasma and all the organisms, it is mainly in the first trimester. As we all know that during the period of organogenesis, the baby can be most affected. The risk of transmission may be less, only 10 to 15% compared to 60 to 70% in the third trimester because of the placental barrier. But the effect of the disease, of the infection, is more severe. So primary and recurrent CMV infections can occur. In primary infection, there is a 30 to 40% chance that the fetus would be affected. Recurrent infection can also occur for CMV, but the chance of fetal infection is much lesser. So basically, it is the primary infection which is the most crucial. How do we diagnose primary infections? The first thing is that the IgM would rise. The diagnosis is not by doing viral isolation or by culture. It is now entirely by ELISA technique. So the IgM would rise and becomes maximum. I'll show you the slides, and lasts for about 3 to 4 months. Then it comes down to lower levels, and slight, levels of IgM may remain for several months. This is very important because, I get a lot of referrals. IgM is positive, advise MTP. It is not necessary because this IgM can remain at low levels for several months. Similarly, for rubella and other infections. And if you look at this graph, you find that this is the IgM which rises first of all, and then it comes down within 2 to 3 months and will remain in low activity for a long time. Then the green one is Ig. This is the IgG. The red one is the IgG, which will come after about 1 or 2 weeks. And then it will go acutely high and remain high for a long time. It can remain high for whole life. Now, how do you know that there is an acute infection or not? There is a test called avidity. So this is basically an affinity test, and we do that test when the IgM is positive. Or there is a 3-fold rise in IgG over 3 weeks. Like in the first slide, I had said that if the IgG rises at this time, so if you do the test at the time of the rise, there should be a 3 times rise over a period of 3 weeks. Then you say it's an acute infection, or when you do the avidity test, because IgM is positive, avidity is low. So there has not been much affinity of the immunoglobulin, and so the avidity, that is how it is measured, that it is a low titer. But if the infection has occurred 3 or 6 months earlier, then it is an old infection, considered an old infection, which is not going to affect the fetus in the first trimester. And IgG sometimes can be of very high titers, it doesn't matter. But IgM also may be present in low titers. But the important thing is that the avidity is high, and it is a number different in different labs. No, they have standardized, but usually more than 50 or 60%. That means the infection has not occurred recently. It has occurred at least 4 or 6 months earlier. So this is the how the low avidity, if you have here avidity testing, then you find that this Ig, this is high, and then high avidity comes after 6 months. So it's very important for us to know what is the immune status of a woman before she conceives, or even if it is an early pregnancy. If we do a baseline IgG, IgM, and we know that she's immune to any of the infections, then we are not worried. Because unless she's immunocompromised or she gets reinfection, which is very rare, it's not going to affect the pregnancy. If you think that IgM is positive, I need to know more, you can do the avidity. You have time for doing the avidity testing as well. So this will give a very clear picture about whether the woman has been infected or not, and whether she is immune or not. If you are suspecting that the woman has an infection, then we need to do prenatal diagnosis But it's very, very important, as I had said, that it is whether the infection had occurred in the first trimester or before 16 weeks. After that, it becomes very difficult and everything. So some of the features are ultrasonography, but then ultrasound is a very late stage. By this time, the infection has occurred, has damaged the organ. And so now you are seeing the effects of the scars. So that's a late sign. But amniocentesis, you can isolate the virus, but more importantly is PCR, easier to do. We can also do CVS, but what happens is that if you want to do PCR, then you need the fetus to develop an immunity. And the immune system of the fetus is there only after 16 to 18 weeks because the reticuloendothelial system of the baby does not form before that. It needs that much time to develop. So all these infections should be done by PCR after 18 weeks and preferably 6 to 8 weeks after an acute infection. So these are the ultrasound findings that we may see in the brain: ventriculomegaly, intracerebral calcifications, cataracts, microcephaly. So by the time this has occurred, it means it has been late and the fetus is quite affected. Hyperechoic bowel, skin edema, these were cases which I had seen, and even high drops. So these would be some of the ultrasound findings. So we can see that there is microcephaly here, and also the ventricles, there is this lined by calcifications, and there are intracerebral calcifications. So the therapeutic options that you have is either you do termination of pregnancy because there is usually not much treatment for the torch infections, or you, in certain cases, like herpes and toxoplasma, you can do fetal therapy. The problem is we do not know, even by doing a prenatal diagnostic test or by looking in the ultrasound, what is going to be the prognosis. So you need to do very good counseling, tell the parents that you do not know how the baby is going to be, because the effects can be not just stillbirths and abortions. It could be that the baby is born and has problems with the nervous system, with the brain. So cesarean section is indicated if there is an active herpetic lesion. It is not an indication in CMV infections. So toxoplasma infection before 24 weeks, we may consider termination, but if they want to continue with the pregnancy, we can start the patient on spiramycin as soon as you know that she is infected. Spiramycin is usually continued till the first trimester, after which, if you have diagnosed that this is indeed fetal, then you can start on pyrimethamine and sulfadiazine. Now, these are toxic drugs and therefore not started in the first trimester, and they are alternated with spiramycin, but you have to do them in tertiary care centers because they are very toxic to the bone marrow. I even had a patient once who had a plastic crisis while treatment with pyrimethamine and sulfadiazine. And though the outcomes have been seen, they're not really free. And the babies need to be taking this sulfadiazine and pyrimethamine for at least 1 or 2 years after birth. For CMV, there is really not much of studies which have shown that they are very, very good for treatment. But there are some trials going on with valacyclovir. But the big problem is that it is again a very toxic drug. So for herpes, we can treat them very safely with acyclovir until the infection disappears. And the problem is that they can again have reinfection. So it's important to see at the time of delivery whether there are any lesions. If in the third trimester towards the delivery, you find that there are lesions and you want to give them a vaginal delivery, you should start them again on acyclovir. So sometimes you may have to give acyclovir throughout pregnancy, and after birth also there should be barrier nursing. For syphilis, we know that benzathine penicillin is the best drug. But if a woman is sensitive to benzathine, then there is really no good alternative, though we have used erythromycin. And it's very important that you resensitize them to penicillin, because that is the best drug. Parvovirus will end up with IUD if you do not diagnose the anemia and treat the fetus with blood transfusions. So once you have diagnosed parvovirus infection, we need to monitor the baby by middle cerebral artery peak systolic velocity for evidence of severe anemia and give the baby blood transfusions. But usually, these infections do not last for more than 4 to 6 weeks. And on its own, no viral infections last so long. So after that, you may not need to give any more transfusions. So how to prevent then? We have talked about treatment and how to manage, but now can we prevent? Yes. Toxoplasma, we must educate our women, especially those who are non-immune, to eat very well-cooked food. Women have this habit of tasting for salt, any food. So they should not do that. And they should wash their hands very nicely and wash fruits and vegetables. They should not handle cat litter. Let somebody else do it. The rubella vaccine is the one which has really transformed, and we do not see congenital rubella anymore. So in India, we do the MMR at 12 to 15 months. And if it has been missed, we can give it at any time, 12 to 13 years. We also have another vaccine, which is the RVAC, and it should be given to all girls at puberty. And if a woman has not received it, it should be given before pregnancy, before planning pregnancy. But she should not plan pregnancy for at least 1 month after the vaccination. It is said that even males should be given vaccination because they may get rubella and infect the women in the family. Rubella vaccination offers long-term protection, even up to 12 to 21 years also has been reported. Usually both the RVAC and the MMR, which is the Tresivac, are well tolerated. However, in some cases, there may be low-grade fever, lymphadenopathy, arthralgia. They must not be given during febrile illness or if there is an allergy to neomycin. And this is not it's not a communicable thing. Some people think that, if I take rubella, I'll be infecting my rubella vaccine, I'll be infecting other people. It is not like that. These are dead attenuated vaccine. And as I said, it should not be, they should not conceive for at least a month. Syphilis, we have been doing this. It is routine antenatal care that we check for VDRL, we check for HIV, hepatitis. Why not for TORCH? In high-risk cases, you need to do that again in the 3rd trimester. However, if you treat late, then you may not be able to eradicate fetal infection. So, as of now, the indications for doing TORCH are if a woman has fever during pregnancy, or a skin rash 3 days, or they have been exposed to somebody with rubella, or they have had some symptoms like lymphadenopathy, unexplained hematological crisis, especially in women with sickle cell, or there is ultrasound evidence of ventriculomegaly, echogenic bowel, intracranial calcifications, cataracts. But I would say that routinely, if we do a preconception TORCH test, we are safe. We know who is immune, who is not immune, and then prevent the problems associated with the TORCH infections and stillbirths. So I think this is all. And my take-home message is that though congenital infections may be asymptomatic, it can cause stillbirths and other problems like congenital malformations, IUGR in the baby. So doing a pre-pregnancy TORCH, IgG, IgM would be very helpful to distinguish and identify the high-risk group of women. Thank you all very much.
Thank you, Professor Decker, for a very comprehensive talk. It was really very, it was an eye-opener. And I would now like to request the Secretary of the Stillbirth Society of India, Dr. Tabheen Khan, to moderate the session and take up the questions.
Thank you so much, Dr. Decker. That was really, very comprehensive, and you have covered everything, almost everything, whatever questions were there in my mind, and the next slide was there with the answers. So I'll just look at the comments that are there. From Dr. Ruchi Bhargav, she says that I routinely do IgM toxoplasma in first visit of pregnancy. Today, a primate tested positive. She's 10 weeks now. Patient wanted a second different lab test. That too is positive. Please guide on counseling and management. And avidity is low.
One big problem that I have faced over this last 37 years, is that the labs are so wrong. Especially some of the labs, they just give such wrong reports. And I like to repeat them. If at all you're repeating them, repeat from a referral lab. Now, the problem is which one is a referral lab. So I think the AIMS lab is the referral lab. And before you take decisions on a termination of pregnancy, as you would have done in this case, because IgM is positive, avidity low, it's an acute infection. It's better that you do it not from that same lab, but do the repeat IG, but you must do IgG as well. You must do IgG as well. And if you do this test, not in early pregnancy, but before pregnancy, it would be more helpful. But please do IgG and IgM and from a referral lab. If, however,
thank you.
the IgM is positive, avidity is low, then you must counsel them that there is a very high risk, that there is a risk of the fetal affection being only about 15%, but it is very severe and it is very difficult to diagnose prenatally whether the fetus is infected, because even amniocentesis cannot be 100% diagnostic. So usually we tell them to consider termination of pregnancy.
Can I ask a question, please?
Yes, ma'am.
Why did you do a toxoplasma? Indication for doing that?
Madam, I think you are muted.
Oh, am I?
Yeah, now,
Yes, now we can hear.
Okay. So I was asking, I have basically two questions. One was about doing torch in the first trimester for all patients. Like, it can be argued because you're doing syphilis, you're doing VDRL. So why not torch? But we're not doing torch as a matter of routine. But this lady who asked the question, she said that she had done an IgM for toxo. My question is, why did you do it? What particular pointed you to do that toxo IgM?
Can I answer the question, ma'am?
Please.
yeah,
Yes.
I asked it because I have suffered. Previously, there was a patient, and at 13 weeks, she started showing signs on the ultrasound. And that time, this thing was positive, and she questioned me that I was actually taken to court for this, that why did not I do a toxo for that patient?
The signs of?
Ultrasonographic signs of torch infection were found at the around 13 to 14 weeks. Not this patient, ma'am. Some other patient. I'm talking of my past history. And I was questioned why I did not do a torch test for her in the first visit. I was asked by the court.
Is it a kind of recommended standard protocol by any agency? I'm not aware about that.
No,
ma'am,
so that is why nothing will happen if you're taken to court. No, it is not recommended.
I don't think, not to my knowledge.
No, it is not recommended, but neither is it recommended that you do ultrasounds every month. People are doing, but the thing is that these infections are there, and I have seen so many infections, and they are all referred very late when you can't do anything, and sometimes even after 24 weeks and all that. So those who can afford, we do it.
That is the reason I was questioned by the judiciary that why I didn't do it, what made me not do it. So I learned a lesson from there. No, I understand it.
But see, these are the things you can always win, because you can always say that there is no recommendation from the ministry or from Foxy. But the thing is,
no
guidelines from a country, because there are very less data.
Royal College and all, are they recommending? And as part of antenatal testing?
That is what I told in my lecture. It is recommended in countries like France, Austria, Brazil, where It's very high. In RCOG,
Their
it is
risk
not
may be much
recommended.
higher.
And FIGO
RCOG does not recommend, nor does ACOG.
WHO or FIGO
No.
do not recommend. Yeah.
No.
No.
Thank you, Dr.
That's what I was
Ruchi.
saying. Means normally we would not do it. Most of the time, it is a post facto problem. That once you
Madam,
are seeing
like
an
the way
intracranial
she, the doctor, what's her name? I didn't catch.
Ruchi, I'm Dr. Ruchi, ma'am.
Okay, Ruchi. So see,
Yeah.
she suffered. So this is the problem. No, why? Not just she suffered, the patient suffered. The patient suffered because we didn't do a torch. So the thing is, if a person can afford, why not do?
That was my only logic of doing it, very honestly.
No.
Yeah.
But
Yes.
I mean, for that matter, so many things can be tested. Simply because a patient can afford, I beg to disagree with that issue. But
Madam, tell us which are the other things.
No, I mean,
Actually, Dr. Dekka
one
is...
can keep testing. There is no end. You talked about an ultrasound being done every month. Is it anywhere listed?
No, I'm
is it
saying
anywhere
I don't
recommended?
do. I do only
I'm not
12
saying
weeks
you are
and
doing.
18 weeks.
But the point is,
A lot
anybody
of
who is
patients are
doing,
being sent
are
for ultrasound.
we recommending that action? Anybody may take any individual action. That is
We are not
for,
recommending.
so
As
that is
of
what
now,
I'm
we are
saying.
not
We are not
recommending.
recommending.
There are no recommendations, but I believe that if a patient can afford it, we should do it, because I have seen, we are not recommending because we don't have data. But I have really seen a lot of cases, and that's why I wrote that book on torch 20 years back.
No, Dr. Deepika, you are very right. You worked at AIMS, which is a referral center from the entire country. Patients may be coming there. But you look at average run-of-the-mill people, they are not seeing even 2 proven cases in their entire lifetime. Proven.
The thing is,
Can
madam,
I just...
if a patient comes and says that I want to do
can
all
I just say
to
something?
make sure that my baby is okay, then torch is one thing you can recommend. I think we can stop this discussion today now here. Go to the next question. You want to say something?
Okay. Another patient presented.
Tamkin wants to say something.
No, I just wanted to say that we are having... I just wanted to say that because Dr. Dekka is, day in, day out, only observing this kind of cases. So definitely, your focus is something absolutely different. And Dr. Reva is bringing another perspective. And I must thank Dr. Ruchi for sharing that the case, and also that saying that she was taken to court. I think that was very brave on her part. There's another question. Another patient presented to her at 13 weeks. History of HSV in early pregnancy. Treatment details not available. What is to be done?
Okay. So HSV, how was it diagnosed?
Ma'am, no treatment details were available. She said she was told she has
sign
HSV.
symptom details?
Nothing. She arrived to me at 13 weeks. She was with some other doctor, and she just said she was told she has HSV, but there was she did not know any name of any medication, nor was there any prescription with her.
So
She's
in that
now
case,
13 weeks.
So she's now 1-3.
13 weeks. Yes, 1-3. Yes.
Okay.
Yes, ma'am.
So basically, they can cause abortions in the first trimester, and you must do a speculum examination. A good speculum examination. I don't think you have the facility. Most places don't have the facility of taking a swab. But now the FIGO says that you don't have to do a swab. You can just look at the cervix very nicely, carefully. Cervix, vagina, vulva. And do an ultrasound. And if everything is okay, you don't have to do anything. If there is a lesion, you start treating with acyclovir.
She has. If there is no lesion, do I have to counsel her regarding any risk of the previous infection she's had in the first trimester?
No, I'm saying if there is nothing and the ultrasound is normal, there is no problem.
Okay, thank you very much. Thank you.
So another question: patient underwent MTP for rubella IgM positive. Can we give rubella vaccine to her for protection of next pregnancy from rubella?
She had an MTP for what?
For rubella IgM positive.
Rubella IgM
so that's
positive.
One very common, Dr. Dekka, common question people ask, whether if she tests positive for rubella, we are supposed to advise MTP.
No, rubella IgG or IgM?
IgM.
See, if there is rubella IgM, then you need to do an avidity. Then you need to do an avidity because you have to time the infection. So if the avidity is low, then MTP is indicated, and this person would have got immune and would not be at risk in the next pregnancy. So there is no worry for the next pregnancy. But I would advise that the next pregnancy
Okay, so that was from Dr.
be conceived after 6 months.
Okay. Dr. Sanhita Dasgupta wants to know if we need to do TORCH IgG for all, IgG, IgM for all FGR cases.
There are studies which show that the overall yield is not very high. So you need to do a very good ultrasound to see whether it is an early onset severe IUGR or whether there are other signs from head to toe, like mild ventriculomegaly, intracranial calcifications, echogenic bowel, ascites. So if there are other signs of suspicious signs of TORCH infections, then we need to do. Or if it is an early onset IUGR, then we need to do. Otherwise, generally the yield is less. But if you're doing amniocentesis for chromosomes, then you may as well do a sample for also PCR.
Ma'am, Dr. Sangeeta here, I had just posted this question. Can I just ask one thing?
Yeah.
So, ma'am, this patient is actually 30 weeks. So 30 weeks Doppler showed everything else is fine. But by ultrasound, her growth is 28 weeks, exactly 2 weeks lag. But rest, everything is fine, like a normal and Baki, everything, no anomalies. And level 2 was fine, everything was fine. So I just wanted to know whether
what about the
I
Leica?
should be. Leica was normal, ma'am. 12.
Leica
12
normal than
AFI.
IUGR?
Yes,
Okay.
ma'am. That's why whether I
See,
should be
in these cases, there is no way that you can diagnose TORCH except by doing amniocentesis. So if the ultrasound is normal, I don't think the yield is going to be too high.
Okay, ma'am.
So can we just, there are many more, cases and questions there. Can we take them later on because it's 8:25
Yeah,
and
sure.
speaker, yeah?
Yeah, can I just put in a word? And that
Yeah,
I
sure.
recently, I keep doing short courses. And just 1 month back, I did a short course on TORCH, going into it in details. So I request those who have attended here today, I saw 100, now it's yes, that you can please attend the short courses, which will give you details about any topic that I'm discussing. Thank you.
So, and not very, those courses are not very time consuming. Just, I think eight modules, 2 hours each. Something
Yeah,
like that.
yes. And you can become members of the OFMAG, the Obstetricians Forum for Academic and Fetal Medical Care.
Very, very, very useful group for, discussing your problems.
Free of cost. Thank you.
Dr. Deepika, answers very, very fast. All the time she's on the mobile helping us out. Thank you so much, Dr. Deepika.
Thank you very much for the opportunity.
Yeah. So thank you, Professor Deepika, and thank you, Dr. Tamkeen. I would like to carry the session forward by inviting the second speaker for today, Dr. Veronica Arora. She's a consultant in clinical genetics at Sir Gangaram Hospital. She has been awarded this certification from European College of Medical Genetics, and she's also the secretary of the Delhi chapter of ANBAI and secretary Delhi chapter of ISOPAV. She's the head North Zone of ISPAT Society and also an advisory board member of the Myositis Society of India. She's a member of UMMID initiative by DBT Government of India. She has published more than 60 papers and book chapters in national and international journals. And she's also the treasurer of the Delhi Society for Fetal Medicine and an executive member of the Society of Indian Academy of Medical Genetics. She's the co-editor of Foxy Focus Fetal Medicine and Genetics, and her areas of interest are reproductive genetics, RPL, fetal malformations, autism, skeletal dysplasia, and dysmorphology. Dr. Veronica Arora, I invite you to share your slides. Dr. Veronica? Hello, Dr. Veronica?
Am I audible?
She's
She's
Dr. Veronica, are you there? You can start sharing your slides.
She's there. She's there. Veronica, please unmute yourself.
Yeah.
Are my slides visible and am I audible?
Yes, yes, they are. They are visible.
And I'm audible, right? Thank you.
Right.
So thank you, Namkeen ma'am and the Stillbirth Society of India for this opportunity. So today we'll be discussing about genetics of a stillbirth and how contributory the genetic testing is to this issue. And we know that stillbirth is a very saddening experience for women, and we want to have the genetics and there's a record. So, stillbirth is generally defined as fetal death in utero after 20 weeks of gestation and accounts for approximately 60% of all perinatal deaths. Thus, the WHO uses two parameters, independently, mainly a fetus without sign of life that is born after completed 22 weeks or birth weight of 500 grams if the gestational age is unknown. It is stillbirth is a key indicator of women's health and quality of care in pregnancy and childhood. Although rates for high-income countries are relatively lower compared with low-income and middle-income countries, stillbirth remains an important healthcare burden. The genetic factors especially do not vary much between the high-income and the low-income group. The death of any child is a tragedy for families, often with profound, long-lasting psychosocial and economic factors. The incidence is high, and in low-income countries.
Sorry to interrupt you, Dr. Veronica. Do you have another device online? Because there is a lot of echo. People are complaining that the audio is not good. So can you check if you're online from another device?
Yeah, now
there's some background noise because only you are unmute and everyone else is muted, but there's still some disturbance.
Now I think this would be okay. Is it okay now?
Yeah, I think it's better.
Can you come closer?
Thank you.
Can you come closer to the device?
Yes. So now I have closed the other device. So I hope there is no disturbance now.
Yeah, it's better, slightly better. Thank you.
All right. So the incidence of stillbirth in high and low-income countries is significantly lower as compared to low-income countries and varies between 4 to 7 per 1,000 live birth. The specific cause of each stillbirth is important, not only to explain the cases, but also to help prevent recurrence and couples future pregnancies. Common root infections, as ma'am has discussed, insufficiency, intrauterine growth, GDM, etc. However, they each other.
Dr. Veronica, we can't hear you. Dr. Veronica?
Insufficiency.
We can't hear you properly. Hello?
We can't.
Dr. Veronica, we are not able to hear you.
I think she's offline, maybe. Let me call her.
Can you hear me now?
No, we can't hear you. We can't hear you properly. There's a lot of disturbance.
Can you hear me?
I think
No,
the connection is poor.
Your voice is, yeah, your voice is breaking. The connection is not proper.
Okay. Is it still breaking because I'm connected to the earphones?
Now it's okay.
Should I reconnect once?
Now it's okay.
Is
Now
it
it's okay. Yeah, it's much better.
Is it better?
You can continue. Yeah, you can continue.
Okay. So you can interrupt me, no issues when you can't hear me. So I'll try to go a little bit slow. So unexplained stillbirth is defined as a stillbirth without the known cause after excluding all the causes as we have listed above. In the presence of fetal malformations, up to 50% of stillbirth have an additional placental finding, which could result in fetal death by itself. So when we have a fetus with malformation, the causation of stillbirth could be either due to the malformation and a genetic cause or due to the placental genetic cause. So they both have to be tested separately. Ideally, in a case of stillbirth, a separate testing for the placenta and the fetus itself is indicated to get the most accurate diagnosis and the highest yield of testing. Am I audible?
Yes, yes, loud and clear. Now it's all right. Please continue.
Okay, lovely. Various studies have shown that this percentage varies between 25 to 60%.
Slides are not moving, Dr. Benolkar. Slides are not moving.
I'm on the same slide only. So now I'm on the next slide. So we come on to the specific genetics of stillbirth and what all tests we need to do and what all tests we can perform. So number one is to identify a genetic etiology or think of a genetic etiology. And we need to study the whole genome per se together to understand stillbirth. Just studying of chromosomes or of genes will not help. So the different tests that we can perform in a case of stillbirth, especially in a case of a recurrent stillbirth, include the following: the FISH test, the QF-PCR microarray, and the two new tests that are now available for chromosomes called optical genome mapping and MLPA. Optical genome mapping is the most superior test that is available for chromosomal disorders in stillbirth and other fetal malformation. The test, of course, we are performing at our hospital. It is a little expensive, but it will cover all the smallest of rearrangements which even microarray will miss. So, as we start with the first test that we can do, stillbirth we know is a cause in even fetuses of Down syndrome because they do have rhythm abnormalities. In fetus with Noonan syndrome and racopathy, they can have a hypertrophic cardiomyopathy, especially in fetuses with a high rate of heart defects, including trisomy 13, 18, 21. We can do this test called karyotype, which will pick up large deletions and duplications. Aneuploidies are best detected by this test. It's costless and it will give you a good answer. And then we move on to the test of genes, where we pick up disorders like Noonan syndrome, where heart defects are important, and hypertrophic cardiomyopathy and rhythm abnormalities, especially like long QT syndrome, can be picked up only by mutations that exist in these genes. Any variants in these genes can cause in these nucleotides can cause long QT syndrome or a Noonan syndrome. So you order a gene-related test, which we will come to. So this is how a gene-related mutation looks like. A normal gene will have a reference nucleotide effect, and a mutated gene will have a different effect, and this can be picked up on your exome sequencing. So for a case with stillbirth, especially a recurrent stillbirth, we need to test all the genes together, especially the cardiomyopathy and the rhythm abnormality related genes. Now we come on to another test, which is known as FISH test. FISH test, as we can see here, is the principle of this test is the hybridization of probes. So when in case of stillbirth do you want to do a FISH test? In disorders like a DiGeorge syndrome, where a rhythm abnormality or a heart defect exists, or a Williams syndrome, we can order specific tests antenatally or postnatally on the fetus with stillbirth for this test. and the number of days you require to get this test back is 2 days. So the indication to do a fish really is to get a quicker report. In most cases of stillbirth, you would not want a quicker report. We would want a more accurate report. So this test can be best avoided as compared to your antenatal scenario where fish test is a must. Now let's come on to QF-PCR. QF-PCR test is important in case of your stillbirth because it detects maternal cell contamination. If you take a piece of your placenta for genetic testing, it is important to perform this test so that you can segregate the sample, the DNA of the placenta from DNA of the baby. The DNA of the placenta is different from the DNA of the baby, and you need to perform this test to understand this difference. And the test should be performed on DNA of the fetus. So when there is a baby with stillbirth, you do a QF-PCR to make sure that the cell you are testing are of the fetus and not of the mother or of the placental tissue. So we need fetal DNA and not maternal DNA. And QF-PCR is the test which will tell us that you are testing on the right DNA. This is the peaks that will appear on your QF-PCR test. A QF-PCR it's a DNA-based test, and it will also tell you about the common 5 aneuploidies, that is trisomy 13, 18, 21, X and Y. On the QF-PCR, you can see peaks like this. Normally, every chromosome will have 2 peaks, as you can see here, 1 and 2, 1 and 2. But if there is trisomy, you will see 3 peaks like in Down syndrome here. Another form of trisomy peak interpretation is this 2:1 ratio. Normally, we will have 2 peaks for all chromosomes, but if there is a trisomy, there will be a very long peak and a smaller peak. So either a 2:1 peak or 1:1:1 peak. So these are the 2 reports which will come whenever there is a trisomy of any particular chromosome. This test has 2 advantages. It is a quick test and it will help in segregating the maternal tissue from the fetal tissue. So this is a must for every fetus with stillbirth, especially when you're going, of course, for genetic testing. Then karyotype, as I just discussed, you do a karyotype when you're suspecting a particular aneuploidy, like a Down syndrome, an Edward, or a Patau syndrome. So now let's come on to chromosomal microarray. Chromosomal microarray will look at all the chromosomes the karyotype looks at, but it's a much better test than a karyotype. It looks at the karyotype in a magnified manner. In a karyotype, we look through our naked eyes into the microscope and see that if some chromosome is missing or is extra. But can we pick up small deletions and duplications? No. So when there are syndromic fetuses with small deletions and duplication, we do something called microarray. If you see the size of these dots, the size of these dots shows the size of probes that are placed throughout the chromosomes, and there are millions of probes, so we will detect the smallest of deletions and duplication. Thus, this test is the best for detecting a chromosomal disorder. So this just shows what is the difference between the conventional karyotype and the microarray we do now. The cost of microarray has come down drastically, and now the cost difference is not so much as I have just shown here. The microarray costs around 8,000 to 10,000 at present. This is how a report of a microarray looks. If you have a baby with stillbirth and we're suspecting a syndromic etiology, especially in addition if there is a fetal malformation, you do a microarray and you check the number of copies that are mentioned here. Normally, for each chromosome, we should have 2 copies. If there is 1 copy or 3 copies, that indicates the chromosomes have been deleted or duplicated. And this we have to then study in detail to be able to counsel the couple about the recurrence in future pregnancies. When we have a chromosomal microarray report, everything that is mentioned on the report is definitely not disease causing, and you have to look at the interpretation after a thorough literature search. a variant which is benign or a variant of uncertain significance, you cannot counsel the patient on the basis of that variant. You need to test the parents, you need to do a literature search, and only when the variant is pathogenic, you can then counsel the family that the stillbirth was because of that variant, and then they can plan the future pregnancy and do a prenatal diagnosis on the basis of that variant. So let's look at some common disorders which cause IUDs or stillbirth, because in genetics, there is a lot of overlap between the genetic disorders causing IUDs and stillbirths. So this is a fetus here. We can see that the gestalt of the fetus has upslanting palpable fissures, a small nose, depressed nasal bridge. So we know that this fetus has the look of a Down baby. Now the Down syndrome is one of the commonest disorder. We have the maximum test available for the same. And on this fetus, we can do the easy test, which is the cheapest, the PCR-based test called QF-PCR. So if you can recognize the cause of your stillbirth or IUD, or even a malformation, you can directly go and do a QF-PCR test. Like in this fetus, there is an overlapping of the second and the third fingers, very high gestalt of a trisomy 18. So you can do a QF-PCR and get your diagnosis. You don't have to do a very expensive large test. QF-PCR will give you the diagnosis when you know what you're dealing with. Here is a fetus where there is cleft ophthalmos and cleft palate. Here we do not know the diagnosis. So we do a more non-specific test called chromosomal microarray, which will look at all the chromosomes together. Here, this baby actually was terminated as there was no heartbeat and there was a massive nuchal edema. And this nuchal edema, we did a microarray to test for any chromosomal disorders, which was normal. And now we do not have a diagnosis. They already had, this was a recurrence for this family. And even after doing the first step genetic testing, that is microarray, there was no diagnosis. And in the last pregnancy, they actually had a hydrops and stillbirth. So we were quite sure the cause is genetic, but we had already tested the chromosomes and not gotten an answer. So then we move on to the next step of genetic testing, that is the gene-related testing. Now, genes are placed on top of chromosomes, and the genes can be tested one by one by using this test called Sanger sequencing, which is extremely laborious and expensive. And they can also now be tested by this really great method of genetic testing, that is next generation sequencing, which looks at all the genetic disorders together. So now next generation based technology has three kinds of genetic testing. That is the exome sequencing, a clinical exome sequencing, and a whole genome sequencing. So whole exome sequencing is looking at all the genes together, but the important part of all genes. Whereas clinical exome sequencing is looking at a limited number of genes related to your phenotype. And the best and the most expensive test that is available today is the whole genome sequencing, but it is really on a research basis right now. So for most practical purposes today, we are ordering whole exome sequencing, which looks at all the genes together. So now, when we have a malformation causing a stillbirth, not an isolated stillbirth, we differentiate malformations from markers, a recurrence of stillbirth for the first time history, and very important, a significant family history. In presence of a significant family history of recurrence, genetic testing is mandatory. In case of a first time isolated stillbirth, we can look at the obstetric causes and then maybe discuss the test according to the affordability. So there are some important points in genetic testing when we take up a fetus for genetic testing. Number one is that for all stillbirth, we like to perform a fetal autopsy, that is the fetal postnatal examination, do a histopathology, do an ultrasonography, and also sometimes do a postnatal fetal MRI to give us much more information before we go ahead and do genetic testing. This is what we call a deep phenotyping. That is the in-detail evaluation of the malformation or of the fetus before we go ahead and do genetic testing. This helps us geneticists to give a better percentage of answers to the patients. So performance of fetal autopsy definitely enhances the diagnostic yield of genetic testing. Another test that we offer to parents of fetuses with stillbirth is the ECG of both the parents. Now, this ECG helps in diagnosing a long QT syndrome. Long QT syndrome has been shown to cause IUD and stillbirth. And if one of the parents has long QT, we then know that we can test for the same. So genetic syndrome have been definitely acknowledged as an important contributor to fetal death, and it has been previously speculated that a substantial proportion of stillbirth, different approaches and methods to detect genetic. As I showed you the journey from a standard karyotyping to fluorescent in situ hybridization to now the molecular genetics and the next generation sequencing, which actually look at all genes together, and a very important test called QF-PCR have really made life easier for geneticists, and with the reducing cost, we aim to go and reach all patients and provide them testing. Genetic testing is very important for all causes of stillbirth. Once, of course, you've ruled out the obstetric causes. If a patient is not interested in testing at any point of time, please go ahead and store some fetal DNA, which is very cheap to store and costs some 300 rupees. And if they want to come back before their next pregnancy, they can do the test then. Couple ECG should be done to rule out long QT syndrome. It's a cheap test and it gives us a good diagnosis if you do diagnose long QT. Family history and recurrence are of utmost importance, because once you have that, you are more confident in testing for the genetic causes. Fetal autopsy has proven to be useful many a times, because sometimes ultrasound misses some malformations or events that we pick up on fetal autopsy. With that, I'd like to end the presentation, and thank you everyone for your patient listening.
Thank you, Dr. Veronica. We'll have the questions in a bit. I would first like to invite our expert, Professor Reva Tripathi, ma'am. She's a senior consultant and head of the Department of Gynae at Sitaram Bharatiya Institute of Science and Research, New Delhi. And she's a former professor and head department of OBGYN, Hamdard Institute of Medical Sciences, New Delhi. And she's retired as the director and professor from Maulana Azad Medical College, New Delhi on 31st of March, 2017. She's a former dean, Faculty of Medical Sciences,
Okay,
Delhi.
that's all right. I don't think you need all that.
Okay,
my statement is, thank you very much. Yeah. I only want to say that I'm not a geneticist, and I don't think I can ask too many questions of the geneticist. But my one question I would like to ask, maybe it was part of the audio, I missed it. What is this connection between the long QT and the evaluation for stillbirths? I didn't get that. Can you clarify that, Dr. Veronica?
Yes, ma'am. Yes, ma'am. Ma'am, thank you for your question. I am very honored to be talking in front of you. I was also an SR in MAMC for some time, so I had worked under you. Thank you so much, ma'am. Ma'am, so basically these long QT syndromes, they have a variable expression. In some, if there is an inherited mutation in the parents and in the fetus, variable expression exists in the fact that it can cause the stoppage of the heartbeat of the fetus by causing arrhythmia, and can cause IUD or a stillbirth. And in the parents, it may be present, the mutation, but may not have caused stillbirth, but may cause early death in the parent later also. So if in a parents of a fetus with stillbirth, we find that there is long QT syndrome, then we can do genetic testing on the fetus related to certain genes which cause long QT syndrome. And in the next pregnancy, we can do a prenatal on the basis of those genes that we have found.
Can you give me some information about what kind of stillbirth would this be? This would be an appropriately grown baby or a growth restricted baby or what? Or will it manifest like a sudden IUD? How does it manifest?
Yes. Veronica?
Please pardon my ignorance on this topic because I don't know.
Can I add something?
And I'm learning.
Dr. Reva, can I add something? Actually, long QT interval has been implicated in sudden infant death syndrome, as well as sudden unexplained IUDs, both.
So that means that it is more applicable for those that are sudden IUDs in appropriately grown babies. It would not be applicable for a growth restriction or something. So over there, you're going to think of other issues.
Right.
Yes, I think. Veronica, we can't. Are you muted?
No, I think
actually this will be going off at 9 p.m.
Yeah.
Okay, we're almost there. So maybe other questions can be taken up.
Ma'am, we request you to give your concluding remarks first, and then we can take the questions.
So in this time, we will take the questions, and Aisha has to give
if
the
vote of. If there's still time left, then we'll take the questions.
You know, I think that there are barely any concluding remarks to make because we've had an exhaustive session from Dr. Deepika Dekar and also one from Dr. Veronica regarding torch infections. I think the problems are magnified a lot many times, and testing should be appropriately done. There are certainly indications where it is required, but I would think that it's done more frequently than it ought to be done, in my opinion. Like, for example, I would beg to disagree about whether it should be done as part of routine first trimester screening and things like that. So, and I also don't really believe in doing torch for RPL. So I think that it should be very clear in one's mind when we are doing torch testing, what the results are likely to tell us, what interpretations we make, and what clinical modifications we may do in our management. So maybe a lecture from Dr. Deepika just for an hour is not quite enough, and we need to go into more depth. So that is about Dr. Deepika's lecture. And regarding Dr. Veronica and genetic testing, I suppose I should say that I probably need teaching myself. So I don't really know. But yes, we are learning as we go along. And we do realize that many times some of the answers that we couldn't give some years ago, we are now able to give with properly conducted genetic evaluation and genetic testing. The only point that comes in is that actually these are expensive tests to some extent. I mean, it's all relative. Question of money is all relative, and who can afford what. And if we really expect a substantial yield, so that means if our index of suspicion is really high, then I think it's worthwhile to motivate family to go in for the testing. But simply just to check some tick boxes, I would be a little skeptical, with due apologies to Dr. Veronica and other geneticists. Thank you.
So Aisha, can you just...
Yeah. So we can just have the vote of thanks from Dr. Aisha, who's also the Joint Secretary of the Stillbirth Society of India. And if we still have time left, then we'll take up the questions. Thank you so much.
Dr. Asma. Maybe I can answer it on the chat, right? The genetic question. Okay.
Yes,
okay.
that.
Yeah.
Thank you.
So, very good evening to everyone. We've had an interesting 2 lectures and interesting discussion on the different questions, and so much still remains. And it's my privilege to have been asked to propose a vote of thanks. On behalf of the society, I would like to express my heartfelt thanks to our chief guest, Professor Reva Tripathi, who spared a valuable time. And despite, there was this 2 webinars simultaneously, one had been postponed or preponed. And ma'am, we are really grateful that you took time and despite everything, and you've encouraged us by gracing this occasion.
Thank you.
It's always a pleasure to hear Professor Deepika Deka. It's not the first time I'm hearing. And today's talk on the tricky topic of torch infections has been really wonderful. The question answer session was great. And on behalf of Stillbirth Society, I want to extend my gratitude to Dr. Deka for enlightening us. And I just saw in the chat box that ma'am is arranging some session on torch infections, and I'm sure all of us would like to join. And I would like to thank Dr. Veronica Arora for introducing the genetic causes of stillbirth. And I'm sure we are all motivated by her amazing explanation of the subtle nuances. And especially that was so interesting, the baby with stillbirth, and you get ECG testing of both the parents. And that's something which I really learned. And at the end, I would like to express my gratitude to our esteemed audience who blessed us with their presence today and contributed to making this webinar a success. Thank you very much.
Thank you, Dr. Aisha. And we have a comment from the treasurer of the Stillbirth Society of India, Dr. Neetika Garg. And she says that although torch test is not included in the investigation plan of RPL, I have faced patients where a precious pregnancy after recurrent abortions landed up in severe FGR due to cytomegalovirus. So now I have made a dictum to include torch, IgM, and IgG preconceptionally. So your comments on that, Professor Deka? Would you like to comment on that?
I don't think it's a cause of recurrent abortions, but it can cause a sporadic miscarriage. So if she has found some lesion which has caused, so that pregnancy might have been because of CMV, not the previous ones, unless she was reinfected.
Thank you.
Thank you, ma'am. It was nice hearing all the sessions. So nice to hear
so
both
much, Dr. Deka.
Dr. Deka and Veronica.
And Dr. Reva Tripathi, we are really indebted, for you just staying with the commitment and being here for all of us and giving us a very balanced perspective. And Dr. Deka, thank you so much. I've just put that course, the PDF only in the chat box. You can all access that course. Veronica, for arranging and giving us very practical examples.
Thank you all for arranging and giving this opportunity.
100 people had joined in, and it was also being live streamed on YouTube.
Ma'am, actually, I could not join when I got disconnected because it said the capacity was full. So maybe, ma'am, so maybe we can work on that, like the capacity for more people to join in.
Actually, the difference is 5 times in the annual.
That is why it was being live streamed on YouTube. That is why.
Yeah. But the thing is, that's the problem.
Dr. Veronica, we have a question for you. Can we do microarray with DNA storage if we are not sure of the abnormality?
Yes, absolutely. So now microarray is one test that you can perform prenatally on or on a DNA sample, even if you're not sure and you just think it is genetic. It is one of the non-specific tests that can be performed, not exome sequencing. So chromosomal microarray we can perform.
You can't do exome sequencing from tissue, fetal tissue?
No, ma'am, that we can do. She's saying the question she's asking is when we are not sure of the abnormality. So then
one question I have for you, Veronica. We were always taking tissue from the clavicle and areas.
Yes, ma'am.
So what do you prefer?
Ma'am, the best tissue with the maximum amount of DNA is number 1, the placental villi. But that has that problem of maternal cell. So after that, we can get some sample from the liver or the spleen. That, then skin, in that order we prefer.
What do you do for placental mosaicism? Maybe that's kind of making it late. We are beyond time.
So, ma'am, placental
No, it's
mosaicism
okay.
is best checked by amniocentesis because the amniotic fluid cells are actually a truer representation of the fetus than the placental cell. So, at 11 weeks, we are suspecting placental mosaicism. We need to do amniocentesis. And the other thing that makes us sure that it is mosaicism is to keep culturing the cells in the lab. The mosaic cells will stop getting cultured, and the cells with true chromosomal abnormality will get cultured. So,
No.
for mosaicism, amniocentesis is the test of choice if we are getting placental mosaicism.
Like kind of many times you missed the bus and you haven't done an amniocentesis, and then some growth restriction or something is taking place later, and you thinking that maybe that is you're thinking of various causes, and placental mosaicism comes in then. So that is why I just thought that to ask you about that.
Yes, ma'am.
No, ma'am, we get a lot of cases. We do get a lot of cases where CVS has been done, and the result is actually a mosaic, and then you cannot take a decision. So in those cases,
then
we
you
have
will do
done
an amniocentesis.
repeated with amniocentesis, or even if you come later, then we can do a cord blood sampling.
Okay, cord blood sampling. All right. Yeah. Okay.
Especially when there is oligohydramnios. When you have oligohydramnios, there's not enough amniotic fluid, cord blood sampling becomes very useful.
Okay, thank you.
One more question for you. If somebody tests positive IgM rubella in the first trimester, do we advise termination?
IgM, yes.
It is better because unless you see, the first thing is counseling. We don't advise anything to anybody. We counsel and let the patients take their own decisions. You would get, like I got patients who, when you explain that there is a 15% chance only of getting affected, then they say, okay, so 85% chance of not getting affected. Then how, supposing, especially if they are IVF pregnancies and they have, are very elderly, nowadays you do get a lot of patients like that who just desperately want the baby. Then you can say that we may do a PCR, amniotic fluid PCR, after 8 weeks. Like supposing she's now about 12 weeks, then we'll do it at 20 weeks. And but then they must know that if it comes positive, then it's fine. But if it comes negative, it's difficult to rule out. But we can also do ultrasound for other features of rubella.
Exactly.
Okay, thank you.
So not always you say MTP.
Okay, so we have one Dr. Khyati Arora, who is also joined today. She's a genetic counselor. Would you like to say something about this, Dr. Khyati? Are you there? Okay. So thank you so much, Dr. Deka. I think more than 100 people were full to the capacity.
Yes,
they all joined because of you and your name and Dr. Veronica, yes. And thank you so much. I think we can have 1 or 2 more sessions later on after a few when you are more free in detail, because there's so many questions that were, or a case-based discussion. We'll be very happy if you can agree whenever you have time. Thank you so much.
So from the society, from the group that we are doing, fetal medicine group, we are having a meeting on the 25th, panel discussion on basically maternal fetal medicine and genetics.
Okay, thank you.
Thank you, Dr. Eva. So nice to see you.
Thank you, Dr. Deepika. Thank you, Dr. Tamkeen, for asking me. Thank you.
Ciao, Veronica. How are you?
I'm good, ma'am. Thank you so much.
Anita, seeing you now.
Hello, ma'am.